only Class 5, 7, and Class 8, it offers possibilities for adapting to special requirements to your age. Our pursuit of excellence has resulted in Oxygen becoming India's first orthopedic implant manufacturing company to receive the prestigious and most competitive or medical device single audit program certification. We have established an in-house medical testing lab. Our extensive medical testing expertise covers static, fatigue, torsoil, and wear testing of our products. The offices in Germany, USA, Mexico, and many more are in a pipeline. Sales and customer totally concentrated. TIES, Division of Oxford Institute of Surgeons Academy's mission is to improve a patient's life through innovative orthopedic research and development. The TIES Academy pays special attention to education and training of many stakeholders involved, including customers, technicians, and surgeons. Not only are we proud of being an Indian company with excellence, but we continue to evolve our technology and serve the best patient care with humility and heart.
Good afternoon, everyone. It is a privilege and a pleasure on behalf of our Zain Group to welcome all of you today. Thanks to you for being here with us. We're blessed to have you with us to participate in the third webinar organized by DICE, the division of Zain Institute for Surgeons, part of Zain Group. As all you know, Zain Group has a division that is in charge with educating our surgeons. Last year, this division was inaugurated here in the city of Miami in a Cadbury lab. The purpose of this webinar is to strengthen the technical requirement of our clients and train our physicians with the knowledge, skills, and confidence. Before we begin, I would like to express our sincere thanks to all of you who has been generously help us to make this event succeed. We will also like to express our special appreciation to the team of panelists led by Dr. Zind, and a specialty to Dr. Zind as our moderator. Dr. Zind is a consultant orthopedics specialized in shoulder and arthroscopy surgeries at St. Parmanand Hospital in Delhi. He will be talking today about anterior shoulder instability assessment. Dr. Joshi is professor and senior specialist at orthopedic surgery and sport medicine on Vardhaman Mahavir Medical College in Safdarjung Hospital in Delhi. His topic today will be arthroscopy, Vankar repair, tips and perks. Dr. Shivastav is an orthosurgeon senior consultant in arthroscopy and a more sport medicine specialty at St. Parmanand Hospital in Delhi, and he will be speaking about humeral bone defect in shoulder instability management. Dr. Babulkar is the head of the Department of Shoulder and Sport Injury at Dinanath Mangeshkar Hospital and Pune, India. Founder President of Shoulder and Elbow Society, India. Head of Department and Director of FNB Sport Medicine Training Program. And he will be speaking about glenoid bone defect management principle and technique. Dr. Kumar is a consultant orthopedic surgeon at Woodin Hospital and Aberdeen Royal Infirmary. And he will be exposing today revision surgery in shoulder instability issues and challenges. Dr. Zin, you take control of this webinar right now. Thank you so much.
Hello, everyone. I, along with all the panelists, welcome you all to this webinar on anterior shoulder instability. I'll just share my screen first. So my topic is preoperative assessment of the anterior shoulder instability. As you all know, the anterior shoulder instability basically has two essential lesions, the Bankhart's and the Hill-Sachs. And Bankhart's lesion is the avulsion of capsulolabral complex from the anterior inferior portion of glenoid. And Hill-Sachs defect is caused by the dislocation when the posterior part of the head is lying against the anterior rim of the glenoid. So it causes a compression fracture there. So to address this, we have different options of doing a arthroscopic Bankart repair, which restores the anatomy by doing a capsulolabral restoration and as well as capsular retensioning. And another procedure is Latarjet, where we are using the bone augmentation procedure. We can also add remplissage to a repair to augment this repair. So in the last 2 decades, arthroscopic Bankart repair has been very popular surgery among arthroscopy surgeons and orthopedic surgeons. And everyone wants to just sort of do this surgery for all instability surgeries. But the results in literature are presenting differently by different authors. Adams, in its meta-analysis, came out by studying 12 studies of arthroscopic Bankart repair. And they found that there's a recurrence rate of 13.7% on an average, ranging from 7 to 20%. And if you consider the athletic shoulders, this recurrence rate even goes up to 20% and more. So this study found that younger age at operation and preoperative glenoid defect, these are the factors which significantly influence the recurrent instability. So why do arthroscopic Bankart repair fail? Pascal Bolo in his study in 2006 identified these risk factors of failure. And he found that if the age of the patient is less than 20 years at the index surgery, the recurrence risk of failure was 31% after Bankart repair. If the level of sports participation is competitive, the risk of failure is 50%, and 33% in contact and overhead sports, and 19% in hyperlax patients. And if you can see Hill-Sachs lesion and glenoid bone loss in AP view on X-ray, the risk of failure of arthroscopic Bankart ranges from 30 to 40%. So he used all these risk factors and quantified them by giving points and came out with this instability severity index score and suggested that if the score is more than 6 and you proceed with arthroscopic Bankart repair, there's a 70% chance of failure. This score has been validated by different authors, including Lupini, who came out with similar results, similar to the Pascal Bolo study, and suggested that if the Bankart repair is limited to patients with less than 3 score, there is significantly less risk of recurrence. But some others have challenged this validity of instability in the score, particularly the radiographic domains. They say that just the mere presence of glenoid bone loss and Hill-Sachs lesion on an X-ray cannot be taken as significant. If you see them, you have to quantify them using CT or MRI to make a decision of significance of the lesions. So most authors would agree that failure to recognize bony defect is the main cause of failure. So Provencher in his study in 2010 suggested that we can have a fair bit of idea about glenoid bone loss from history and examination. So in history, if there's a high energy mechanism of injury, or if the arm is abducted more than 70 degrees and extended more than 30 degrees at the time of dislocation, if most of the instability is in the mid-range of abduction, if there is progressive ease of instability, and if there is a prolonged history of instability, these all things in history would suggest that this patient may have significant glenoid bone loss. And also in examination, if you see apprehension is positive in the mid-range of abduction with lesser amounts of external rotation, this would also suggest that this patient may have significant glenoid bone loss. And when from your clinical examination and history, you have a suspicion, then you have to evaluate it both on the glenoid and humeral head side. We'll do it one by one. While assessing the glenoid, you can do it by X-rays, CT, 3D CT, MRI, and arthroscopy. However, end-phase view of the glenoid on a 3D CT is a benchmark which is accepted by most for best quantification of the glenoid bone loss. And while you are quantifying the glenoid bone loss, there are main two issues: how to estimate the original glenoid shape and how to express the defect size. So best shape of the original glenoid can be found out by using the best fit circle of the inferior 2/3 of the glenoid. And also you can use the contralateral shoulder as your reference. And the defect size can be measured by using a area measurement or a linear measurement. Although linear measurement is easier to do because it does not require any special software. So different authors have suggested different methods for quantifying the glenoid bone loss. We'll see a few of these. First is the surface area method, where we just use the end-phase view of the glenoid and draw a best fit circle over the inferior 2/3 of the glenoid and digitally calculate the surface area of the glenoid and the osseous fragment to calculate the percentage of bone loss. Another area method is the PICO method, where we take the normal shoulder as a reference and draw a best fit circle and get the surface area of the normal shoulder by using multiplanar reconstruction software. And then you just superimpose this circle on the defected glenoid and calculate the amount of bone loss. Easier method to do is bare spot method, where on a CT only you identify the bare spot and measure the distance from the bare spot to the posterior glenoid rim and the anterior glenoid rim, and take the difference and divide by 2 and get the percentage of the glenoid bone loss. So once you have found the percentage of glenoid bone loss, then next thing to decide is what percentage of glenoid bone loss will be critical for you. Burkhardt and DBR in 2000 identified if there is an inverted pear-shaped glenoid, it's a significant bone loss for the glenoid, and they suggested bony augmentation in these. Low et al. Also in 2004 had a similar finding that if there is a more than 25% glenoid bone loss, it would appear as an inverted pear-shaped. Bolo in 2006 also identified that glenoid bone loss of more than 25% is predictive of 75% of failure after arthroscopic Bankart. So this 20 to 25% of glenoid bone loss has been generally accepted figure by most authors. Now coming on to Hill-Sachs lesion, this is present in 84 to 93% of shoulders with recurrent dislocations, and this lesion is mainly related to end range instability as compared to the glenoid, which causes mid-range instability. So for risk assessment of the Hill-Sachs defect, there are two methods. One is dynamic method, which you do intra-op after you have done the Bankart repair, and you find that by moving your shoulder through end range of motion, you find whether the Hill-Sachs is engaging or non-engaging. Although this would not be ideal since you are putting your repair to a great degree of stress by doing this test. And the other method is glenoid track concept, which you can use preoperatively to find which lesions are significant and which are not. So this glenoid track concept is based on the principle of bipolar bone loss, and it not only gives you an idea about glenohumeral bone loss, but it also helps you in deciding the treatment option for this. So this is basically done by, if you see the figure A, it's a normal glenoid end-phase view, and you take the 83% of the glenoid width as the glenoid track. And in the figure C, if the glenoid is deficient, then this track is also reduced because you have to reduce the amount of deficiency from the track. And if you superimpose this track on the humeral head, so this straight line on the GT in figure B is the cuff attachment line, and circular dotted line is the Hill-Sachs defect. If your Hill-Sachs defect is found lying within the glenoid track line, this is an on-track lesion. And if your Hill-Sachs defect the medial border of the Hill-Sachs defect goes out of the glenoid tract line, it's a off-track lesion. So this Yamamoto and Etoy, they did a study based on this track concept, and they used the surgical options based on this concept only, and they found that the recurrence rate was reduced to 4.3% in their study. This was further validated by different authors. Joel Locker in Arthroscopy Journal in 2016 retrospectively analyzed 100 patients of arthroscopic Bankart and found that the recurrence rate was 6% in on-track lesions and 33% in off-track lesions. Another validation of the glenoid tract by James Shah in his study of 57 shoulders treated by arthroscopic Bankart, and he found less than 8% recurrence in on-track lesions and 75% recurrence rate in off-track lesions. This study suggested that the positive predictive value of an off-track measurement was 75% compared with 44% for the glenoid bone loss for more than 20%. Once you have done the pre-op assessment and you have decided that you're going to go for an arthroscopic Bankart, you can do the final assessment while doing arthroscopy and assess all the soft tissue quality and glenoid and bony defects on the humeral head side. And even then, sometimes you are in for a surprise that you find that the soft tissue quality is not good for repair and you have to change your mind. So in his review, White et al. In Journal of American Academy of Orthopedic Surgery in 2019 gave out this algorithm approach for choosing the right procedure for these patients of anterior shoulder instability. So in his view, if the glenoid bone loss is less than 25% with a small Hill-Sachs, which is on track, you can safely go ahead with arthroscopic Bankart repair. And if your glenoid bone loss is less than 25% with a large Hill-Sachs, which is off track, you can go with arthroscopic Bankart, but you have to add a remplissage procedure to it. And if your glenoid bone loss is more than 25%, or you have poor soft tissues or failed Bankart, you should consider Latarjet in these patients. So to conclude, bony defect is the main cause of failure. Clinical and radiological assessment is the key to recognize the bony defect. The track concept gives you an idea of both humeral and glenoid defects, and the right procedure should be selected according to the patient profile and pre-op assessment. Thank you. So I basically was focusing more on assessment of bony deficiency rather than soft tissues, because I think this was identified as a more common cause of failure. So next talk is
Dr. Rajavan?
Yes, sir.
So what's your preferred investigation for a patient with shoulder instability?
So starting investigation would always be like an X-ray of AP and axillary view of a shoulder. And every patient of mine would get a MRI as well of the shoulder. CT ideally should be done in all cases, as this is the best tool to investigate the bone loss. But I reserve it for patients in which I suspect bone loss based on my clinical findings and MRI.
But if suppose the patient comes with multiple dislocations and with examination and history or suspecting bone loss, still you will go for MRI?
Yes. Yes, MRI is the first investigation in my view, because it will not only give you the soft tissue structures which are injured, but it will also give you details about the additional injuries. You may find flap lesions, posterior labral lesions, or cuff lesions, which you will miss if you don't do an MRI.
Okay.
Joban, if there's a borderline bone loss of say 15%, and the MRI is notorious for underdiagnosing this, there's a chance that you can get caught out on the table and go in and find that the MRI did not reveal. In this case, have you faced that situation?
Yes, And that's what I said, that final assessment has to be on arthroscopy only. Sometimes you have to change your procedure at the final step only. But most of the decision making should be pre-op in case of shoulder instability, because we have good tool of investigations available with us to correctly assess the defects.
Okay, can I ask Dr. Kapil Kumar, what's your opinion? What will be your sequence of investigation?
Thanks, Shekhar. So for me, the first thing, they all get an X-ray, but if they've had a radiologically documented dislocation which confirms a traumatic dislocation and then relocation views, I may not choose to repeat more X-rays. For me, I need to get information both about the soft tissues and the bone defect, because if we know that work from Mike Robinson in Edinburgh has shown that up to about 33% of people after first dislocation have got some degree of bone loss. So for me, that is very important to quantify that, because I'm sure Harjobhan's talk and others, you and Ashish are going to talk about that as well. One of the biggest causes of failure of instability surgery, apart from poor surgical technique, and I'm sure Deepak will tell us about that, is failure to recognize an underlying bone defect. So for me, my standard practice is all my patients get an MR arthrogram and a CT scan. If I had to choose one investigation, and if I've got a radiologically documented dislocation, then I would do just a CT and not an MR arthrogram. But for me, all my patients get MR arthrograms, and that allows me to look at any unrecognized or extent of the labral lesions. Cuff pathology, I would be the devil's advocate. You've got a radiologically documented dislocation. What determines what procedure you're going to do is determined by the bone defect. But you still need to know the soft tissues. So my investigations are an MR arthrogram and a CT scan.
Okay. But as Ashish told that in a borderline case, the MRI may not detect the bone loss. But if it's a significant bone defect, then you can pick it up even on MRI, isn't it?
Yeah, but I do MR arthrogram and CT scan. We have learned from over the years with all the new evidence coming with unrecognized bone defects. I think it was a 2018 paper from John Tokish's group, which have now recognized that it's about 17% bone loss is on the glenoid is the critical bit, above which you've got a high failure rate. So we are constantly evolving. The key is to determine the bipolar bone loss. And what I've found is that the MR arthrograms do not pick up the bone loss, because if you've got minor bone loss on both sides, then if you look at the paradigm and you are then coming to maybe doing something bony rather than relying on soft tissue procedures. So I would do both MR arthrogram and a CT scan.
Deepak, in your center, you do a lot of arthroscopic Bankart. Okay.
Yeah.
And so yours is also a government institution where I think there's no constraint on doing investigations. So you also go for CT scan in every case, or what's your protocol?
If I need to do one investigation, multiple dislocations, recurrent dislocation, anyway, I am going to go for surgery in this. So one investigation, then it's a 3D CT scan, but I would always like to do an MRI to rule out any other soft tissue lesions that may be missed, may have been, that I would be aware of when I go for any intra-articular procedures. But definitely, if 3D CT scan generally be done in most of the cases of recurrent dislocation, multiple dislocations. So we do quantify on CT scans.
And what is your approach, Kabulkar sir? So you have to unmute.
My approach is I try not to rely on the radiologist. Having said that, most of you are aware we are served by one of the best radiology teams across our practice. But it's as a surgeon, I need to be confident what I'm doing, and so.
I think the connection is lost. Anyway, what Harjovan said, I think the intra-articular, definitely we have to go with a broad mind. We cannot go with a prefixed mind. We are aware that this is the bone loss and this is the tissues. So we do explain the patient. We may have to switch from one procedure to other depending on what we see.
MRI will tell you. But it is that borderline case where you're not sure whether the Bankart or letter. If you are in doubt, if you have only one investigation, then the CT can't go wrong because the labrum tear is there, you're going to see it. In case there's a slap, your scope is there, you're going to repair that anyway. But the repercussions of missing a bone loss are huge. That's our way to look at it.
Okay.
Then,
So-
sir, we can proceed with the next talk then.
Yeah, but there's a question, Harjovan.
Yes, so there's a
I think-
question.
I'm answering that in the text. I think probably I should answer that question. It's about selective advantages of MR arthrogram over an MRI scan. I can send it by text, or I can just answer that question if there is time.
Yeah, we can do that.
Yes, sir, you
So-
can answer that.
Yeah, so it essentially, in my practice, we don't have a very high fidelity MRI scanner.
Take it live, Kapil.
So, to answer the question about the selective advantage of MR arthrogram over an MRI scan, I think it depends on the quality of your MRI scanner. We don't have a 3 Tesla MRI scanner, and over the years we've relied on MR arthrograms. It allows us to pick up subtle labral lesions. I think the MR arthrogram comes into fore where we have somebody with subtle instability, not a radiologically documented dislocation, where you're worried whether you are dealing with instability or other pathology. And I do realize that Ashish Babulkar will probably disagree with this because he's got a very good MRI scanner and access to very good radiology service. So in my practice, as I said, to pick up these subtle lesions, I'm more confident picking them on an MR arthrogram rather than an MRI scan, probably because of the quality of my MRI scanner.
Okay.
So there's no more questions, so we can go ahead with Dr. Deepak Joshi's talk. So over to you, sir.
Yeah, thank you, the organizer. So my talk is straightforward. It's the Bankart repair the arthroscopic way. So what should we take into account when we are doing? So this is one of my very older presentation when we started doing Bankart repairs. So for the past, we have learned we used to do putty plat, open Bankart, open various procedure, Boy-Chef, and all those things we were doing open procedures. But we have realized that we were trying to find a simple, effective, and reproducible procedures complemented and facilitated by rehab, minimal bone loss, and acceptable complication rates. So these were the procedures. This is the procedure that we were looking for, that we came in the form of an arthroscopic Bankart repair. So typically, as Harjovan said, that the instability is the anterior, and what is Bankart? It's a lesion of a labrum. It's a group of injuries of a labroligamentous complex located from 3 o'clock to 6 o'clock position when we look at the glenoid in a clock way. So it's, as you can see, it's from 3 o'clock to 6 o'clock anterior, and we can have a posterior lesions too. Types, when it's a simple labral tear, it's a soft tissue Bankart that we see more often associated with a small chip when we call it an osseous Bankart. We can have a Perthes lesion where when we go inside the joint, it looks like a normal labrum. When we probe it, we can actually detach the periosteum and the capsule, and then it is called a Perthes lesion. ALPSA is another common variant that the beginner should look for, that if we don't see the labrum is somewhere below, so we should try to see from the superior pulton and try to detach it, elevate it, and bring it above. So we should try to identify where the labrum is, and it can be associated with a cartilaginous lesion, which is a flat glenolateral article defect. So Hill-Sachs, again, the Harjovan has very nicely told, it's a impaction. Every instability is a bipolar region. That's what we believe in most of the traumatic instability, traumatic dislocations. And we have to take care of both the anterior as well as the posterior, the Hill-Sachs component, when we decide whether our soft tissue Bancal repair will be successful or not. So the treatment has evolved over the past few years in terms that we now better understand that it is not just the double breasting of the subscap. All that is we don't have to just prevent the head from dislocating out, but we have to treat what is actually damaged. That is the labrum. So if the labrum is torn, then we have to retension and repair the labrum so that we have a good proprioception. So the patient feels that everything is normal inside, and we can really go ahead with all the sporting activities he wants to do. And the technology, we have very good anchors now. We have all sorts of anchors, thin anchors, which creates a very small hole on the glenoid, and the surgical techniques. And over a period of time, I think we all have evolved, and we have good number of arthroscopic surgeons who are practicing now. Advantage of the arthroscopic way is, and as with any other surgery, it's a minimal surgical trauma. We can treat everything. We can treat the Hill-Sachs, we can treat the Hagel, or we can treat the slap along with it. And it has lesser soft tissue dissection and the shorter surgical time, and the patient recovers. The movement, the most important thing with the open, that was there with the open procedure, the loss of motion, that is not there when we do it in an arthroscopic way. So what is our goal? Is to restore retention and repair. That is what is the aim. So whatever is, as with an ACL or knee lesions, now in the shoulder also do, it is restore what's the anatomy. Whatever is torn, where it is torn, just repair that thing. So if the labral is torn, stitch the labrum to the place where it was there. If the capsule, along with that, you retension the capsule and restore the length of the glenohumeral ligaments in an arthroscopic procedure, so that the patient has good proprioception. Patient feel better that everything is normal inside. So that's a normal, on the left side is a normal labrum, and that's how when I probe it, the labrum is torn. That's how the Bancal lesion looks. Again, it will be discussed again and again. This is how we have evolved in last few years, that we have started doing lots of remplaçages. I think Dr. Shekhar will also tell about. For a successful Bancal repair, good results, we have to look for the defects on the glenoid side and on the Hill-Sachs. So if it is less than 25% as by the Itoii and Burkhardt, it's on track. Then go for an arthroscopic Bancal repair. If it is off track, add something to it. Dr. Shekhar will tell. If it is more than 25% on glenoid loss and on track, then we can go for a Latarjet, and more than 25% off track, go for Latarjet, remplissage, or a humeral bone grafting along with it. But this is an old study, I think 2012 it is. So now we are accepting less and less bone loss on the glenoid side. So, and some studies have stated that if it is 13% or more loss in an contact athletes, we should go for a Latarjet in those. So we should know what exactly we want to do. So good patient selection and the surgical technique is very important. Do a detailed examinations. Look for the number of dislocation. If it is more, if the patient is able to reduce himself, go look, as was discussed earlier, go for the CT and evaluate the patient pre-op, what exactly you want to do. Want to do an arthroscopic way, or you have to add something to it. So contraindications, so we have a significant bone loss, gross capsular insufficiency, voluntary dislocators. So we try to be a little bit reserved in a simple arthroscopic Bancal repair when we do look for these conditions. Principles are, we have to mobilize, release the labrum so much that when we repair it, we have a tension-free repair, so that the repair doesn't go off when the patient is awake and when the patient is doing exercises. Use minimum 3 or 4 anchors. Perform a capsular tuck and address for the laxity of the capsule, and do patient should be a coper. Patient should be ready to go for a supervised rehabilitative program for about 6 months. If the patient is not ready to immobilize himself, not going to follow, then don't go for this procedure. So again, this is one of my very old videos. So looking from the posterior portal, we use 2 standard anterior inferior lateral, the portal standard anterior and the superior portals. So we can see how much release we are looking from the posterior and working from the anterior portal. You can see how well we release the labrum so that we have a tension-free repair. And this one anchor is put. So these are the older times. So the first anchor is at around 5:30. This is at the level of bare spot. You can see this is the bare spot. So that is around 4:30. And we should, again, as I emphasize, we have to do a tension-free repair. So we should release it properly. And as you can see, we are shuttling the suture. While we are shuttling the suture, look at the anchor. The eye should be at the anchor. There should not be movement of any sutures on the at the anchor side. So we are not offloading the anchor. So we can take a good wide little bit of capsule and a labrum. And the aim is inferior to superior shift. So we are retensioning the labrum as retensioning the capsule, the glenohumeral ligaments from inferior to superior area. So we are aiming the side to side repair as well as inferior to superior shift. So you can see in this anchor, this is the second anchor at the level of around 4:30 position at the level of bare spot. So this is a classical way we do when we have a simple soft tissue Bankart lesion with us. So that's how it, now we are tying the knots. You can see we can have a good bumper effect. The anchors are placed on the face of the glenoid 2 to 3 millimeter inside so that we can have a good bumper effect. So nowadays we have, these are those, as I told you, we have stopped using metal anchors. We are most of the times, we were using biocomposite anchors. Now we have switched on to the all suture anchors. So those are the anchors because those anchors are very thin and they don't damage the cartilage that much. So that's how the third anchor is put. Third anchor is at 3 o'clock. 3 o'clock is basically at the level of the upper border of the subscapularis. So 1, 2, and 3. So we can have a good chalk block effect. You can see the bare spot. One anchor is above the bare spot, one below, and one it is at the level of the bare spot. So that's how we do. And again, we look for the concomitant pathologies. So knotless anchor, we used to do lots of knotless repair. Now we use most of the times when we are doing a bony Bankart, we put a knotless anchor below and above and a knotted at the level. So that's how we do now. But this is just for the sake of showing that we can do the repair in a knotless way. So we have put 2 anchors already. We have passed the suture lasso through from the anterior portal, retrieving from the superior portal. And we pass a wire through it. And we pass a fiber wire. And then we put a knotless way. Principles of the repair is very important. We have to see that there is no much of a bony loss. I had videos of that. I think Dr. Shekhar will show this. We have to intraoperatively assess how much bone loss is there after assessing onto the CT scan before. And mobilize the tissue well. You can see how well the labrum is coming onto the face of the glenoid, creating a bumper effect as we hammer the anchor in. So this is a push lock anchor that we used to do, and we still use in selected cases these types of anchors. So that's how the repair is. And again, that's a remplissage. I think Dr. Shekhar will show. We have to look for, I'll just make it forward. So we put in this video, I just want to show you, want to do a remplissage. So first put the remplissage anchors and take a tissue, bite along with it, and then do a classical Bankart repair. So this is how again the Bankart repair is being done. So the idea what I want to show with this video is that you have to assess the concomitant pathology. The soft tissue Bankart repair will be successful only when you treat the concomitant pathologies along with it. I think I'll skip this. So post-operatively, patient, we generally immobilize for about 4 weeks to 6 weeks. Patient is allowed to do normal activity like brush, tying a belt, and ABR is avoided. At around 4 weeks, we start doing the external rotation. Aim is that for first 6 weeks, we have some immobilization, and about 6 to 12 weeks, we aim is to gain full movement, and after that, we gain full strength in about 6 months' time. That's how we start then allow to play. So with the advancement of techniques, recurrence rates are now comparable to the open procedures, but the arthroscopic technique addresses the actual pathology, the Bankart lesion. It also enables to address the concomitant pathologies, and with meticulous techniques, most of the bony deficiencies can be managed. So one has to be careful while doing the Bankart. When we put an hardware inside, the anchor has to be put below the articular margin with a firm purchase in the subchondral bone, so that the anchor is not pulled out, and also it doesn't damage if it is proud, then it will damage the overlying cartilage. You have to place 3 anchors at least. That's what we believe. 3 or more anchors has to be put below the 3 o'clock position. If you try to repair above the 3 o'clock position, you will end up in having a loss of external rotation. And the anchors are, first anchor is around 530, then at around 45 degree to the articular surface. The second is at the bare spot, and the third is at a level of 3 o'clock. When you have an ELPSA lesion, look from the superior portal, mobilize the tissue well, bring the entire capsule and tissue to the level of the joint, so that when we repair it, we don't have a repair in tension. So we have a tension-free repair. And if you have a Hagel, you have to repair that thing. Hill-Sachs, you have to tackle that thing. So if the bone loss is around less than 15%, we can just go for a simple soft tissue repair. 15-25% is a gray zone. We have to vis-a-vis, you have to carry out which repair you want to do, a bony repair, bony Bankart incorporation within remplissage, or a Latarjet, and if more than 25%, I think we have to go for a glenoid bone reconstruction. So the success for the arthroscopic Bankart is the correct patient selection, good surgical technique, treat the associated lesion, and the practice, of course, the practice is the most important aspect of it. Thank you so much.
Thank you, Deepak sir, for a nice presentation and very good videos. On request of Dr. Babulkar, we are taking the questions for this talk after this Babulkar sir's talk. So over to you, sir.
Thank you, Harjoban. Thanks, Shekhar, for this webinar. And good afternoon, everybody. Trust everybody is well and are safe in this current very awkward situation. I'll highlight a few of my thoughts on the glenoid bone defect, and Shekhar said that he would like me to allude to both the bony Bankart and the bone loss on the glenoid side, and these are quite often mixed. So I'm going to kind of cram 2 different techniques or principles within the same presentation in a 15-minute thing. So firstly, for the youngsters, for the fellows, let us make a very clear distinction between what is normal glenoid, what is bone loss, and what is bony Bankart. And I say this because I have had a couple of queries from fellows, and I have revised a couple of cases where the surgeon was relying on an MRI, went in and found a bony Bankart and quickly did a Latarjet. And so let me make this very clear that the Latarjet is for chronic bone loss and not designed to handle a fresh bony Bankart. And a fresh bony Bankart, we would do our maximum to go and do an anatomical repair and retain the fragment, and that integrates quite beautifully. So the Latarjet is not a solution for a difficult, big, or major high velocity injury as such. So having cleared that thought, then we'll proceed. The other query can be, I have often received this from my fellows, that what's a glenoid fracture and what's a bony Bankart? So anything that is secondary to chronic instability related to a throwing athlete is likely to be a bony Bankart. We're not dealing with that single episode where the first time he's had a road traffic accident and has taken the anterior column of the glenoid off. That becomes a glenoid fracture and should be treated like a glenoid fracture, because then the classification and the Eidberg and whether associated scapular injury is a completely different ballgame. So let's not go down that stream. Irrespective of whether there's a bony Bankart or a glenoid fracture, what we must understand is that fracture fragment is rendered avascular, which means that the fragment derives its vascularity from the parent glenoid. And if you leave it like that, it is less likely to sustain and over time will shrink progressively, leading to a glenoid bone loss. So, as I said, the trigger for operating a patient with a bony Bankart should be higher, your threshold should be lower, and I would go and fix them more commonly rather than the one without the bony Bankart. If you believe Sugaya's series, he says 80% of his instability patients have some form of bony fragment. And surprising where you don't see anything like this patient that you're seeing here was diagnosed as a standard Bankart. We went in and then there's a flake of bone always attached to the labrum. We would preserve this, treat it like a Bankart, but that flake of bone probably helps a better quality integration, which just means that you need a much more judicious technique of bringing that back into place as if you're reducing a fracture. I'm not sure whether it's related to a high velocity injury. It probably is in the younger individuals, but in the elderly, it's probably related to the osteoporotic bone. Try not to rely on your X-rays and MRIs for diagnosing bony Bankarts, especially if you're relying on 1 Tesla, 1.5 Tesla. The 3 Tesla images that we are now used to are very good at picking up these changes of gray shades on the MRI. Ensure you have bleeding surface. So when you have a bony Bankart, you're going to freshen both the fragment side and the glenoid side, and perhaps sometimes use dual anchors. So I see a much more preponderance of bony Bankarts in post-Bankart failures because the previous anchors present as a stress riser and the fracture line passes through them, number one. And number two, consistently, if I have an elderly lady who's had a dislocation, invariably they dislocate with a chunk of bone because of the ensuing osteoporosis. If you have a bony Bankart, your options are, if it's a big one, you can use a CC screws. That's more in tune for the glenoid fracture patients. Most of the time, you're going to treat them with an anchor. The flake that you saw with the previous video we treat it like a Bankart repair. And the ones that are rather bigger are kind of going to tilt if you use a single row Bankart. And today I would probably emphasize more on the double row technique just so that you're aware of it. Now, this is a typical, she's a 50-year-old lady, fell at home in an awkward manner from a landing and no history of dislocation, but she wouldn't allow us to touch her because she was grossly unstable. I immediately sense that if you look closely to the anterior column, you can see something funny there. There's a double cortical shadow there. And so you do a CT scan, and a 2D CT scan shows a small flake, and you say, okay, this is undisplaced, and I could treat this conservatively. But the real giveaway is the sagittal reconstruction of the 3D reconstruction of the sagittal glenoid. And Harjoban alluded to this. I'm not sure how many of you were keen, but this is a very, very important part of his presentation, that you must ask for a 3D reconstruction with a sagittal reconstruction of glenoid, subtracting the head of humerus. Now imagine if the head of humerus is not subtracted, then you're going to miss out on this. And it might look like a very trivial fragment which is in position, likely to heal. For the glenoid bone loss, there's a very simple sign which is twice been reported as if it was reinventing the wheel. There is double cortical sign where you can see here on the X-ray in the B column on the right that it has lost its cortical shadow. Usually it's about a 20% glenoid bone loss that will lead to a positive double cortical sign. For the bony Bankart, there is no guarantee that it will heal because it's, I think, a much more challenging surgery than a conventional Bankart. This is another patient, middle-aged, again, something funny looking, seen at the anterior glenoid. And the 3D images show a large, big triangular fragment. The fragment is thin. It is like a papad. And it's difficult to fix this with CC screws, and it's likely to shatter. And Sugaya has a bone stitcher that passes sutures through the bone. I'm not very good at this, and my worry is that I might convert it into a comminuted fragment. And so my preference is suture anchors here. And this is the 6 months post-op reconstruction. The fragments integrated beautifully. On the X-rays, you'll see metal anchors because initially this is a case from about 10 years back because this is osteoporotic there, you're passing the anchor through the fracture site. I was very concerned about the purchase quality strength. That's why I use metal anchors for the lateral row, and I use a peak anchor for the medial row. But now I think with the peak anchors coming in, and we have a much better quality of anchor, so we need not use metal anchors as such. This is a much more recent case, 6-7 months back. Again, if you look very closely at the X-ray, you can see there's some disruption in the cortical line, and that should be a very subtle sign, and that should alert you that I need a CT scan for this patient. In fact, this lady came in with an MRI initially. This is the actual CT scan, and you see, oh, that's okay. Looks just like a small crack in the bone. And this was an initial MRI. This is a 3 Tesla MRI, and you could see, oh, well, looks okay. And we are good to do a bony Bankart. She's 62. And there you see that there's a fragment of bone there, or there's sometimes just a blunting of the anterior edge of the glenoid. And the actual CT is deceptive. So it's very easy to be befuddled on why is this lady so unstable. And the sagittal sections are much more revealing. So always insist on 3D. And if you don't have the resources, it's sometimes we bring the CD of the CT scan and we do the 3D reconstructions on Osiris ourselves. So she had a loose body. You could see this the view from the anterior portal that looks reasonably okay. And it looks innocent because the bony fragment is trapped underneath the labrum. But the first thing I would do is put in a double-loaded anchor with 4 sutures in there. And that has to go far more medial, far beyond the labrum. And that's tricky because you're crossing the brachial plexus while you're doing that. And the best part of the technique of using double row suturing is you don't need to pass it through the labrum or through the fragment at all. So once you've got the medial anchor, Bob's your uncle, because it's a much more easier procedure. And I'll give you the principles of that. And this is the 3-month CT scan where fragments integrated beautifully in this patient. Just to give you the principle of this technique, let me speed up this video a little. Here you have a bony Bankart, and the fragment is displaced medially. My idea is to come in and use the superior portal, pass in an anchor far more medial to the fracture site. This is typically going to be a double-loaded 5.5 anchor. Once you've had this, then the smart thing to do is to try and get those sutures underneath on the medial side of the labrum inside that fragment. And so this is tricky because you're coming with a very, very medial portal. So you need to see the axillary nerve and then do this. Don't do this without identifying the axillary nerve. Once you've done this, then the rest bit is very tricky. You just put in 2 standard anchors, 2.8 or whatever you choose. Typically, we use PEEK or the bioabsorbables. And you put one of them at around 530, the other at around 230. And the idea is just to mate these. So this is the pulley technique. We use the medial suture to mate with the lateral suture without having to pass them through either of the ligament or the fragment. So here you pick up one set of sutures, and you could do alternate sets as well and tie them with the one pair. And so they actually reduce the fragment and pull them in. So you're not messing around with the fragment. You kept the fragment in toto, and it actually pulls in and reduces the fragment together. The only challenge is getting that medial anchor in place without having to deal with the nerves on the medial side. So this is our final picture, and it's a very robust, very strong repair. And it obviates the question of dealing with the rough cancellous bone inside, because that is a very weak bone. So here, that's the first anchor coming in medially. That's usually a double-loaded anchor. And then you have 2 more anchors coming in on lateral. Let's move quickly to the glenoid bone loss. As Harjuban very correctly represented there, there are enough techniques. Now, it's very nice to speak in theory about these techniques. In practice, especially in a busy practice, it's impossible to do these on your own. And then you want your radiologists who are also equally busy. And if they make errors in judgment, then it's your patient and your practice that is going to suffer. I find this fairly impractical to do all these logarithmic calculations, and I'm very calculation agnostic. So our technique is very simple. get the data on CT scan of both shoulders and measure the widest AP diameter of the lower sector of the glenoid and compare the dimensions. And on the top, you see on the normal side is 25, on the affected side is 23. So there's just a 2 mm bone loss. And this is perfectly okay. Every millimeter bone loss equates 4% glenoid bone loss. So when you have a 5 mm bone loss, you're dealing with a 20% glenoid bone loss. As such. The options in the presence of a bone loss are, of course, Latarjet. You could decide open arthroscopic. You could decide whether you want the Walsh classic technique with the CA ligament or the congruent arc described by Jody Beer. We won't go down that. It doesn't matter whether you do open arthroscopic or whether you do either of technique. Whatever floats your boat, you can work on those. When to use the ICBG is again another issue, and we'll deal with that. And the Bristow, I think, is pretty much historical. We don't need to go down that line. These are videos of arthroscopic Latarjet, but the same exact principles apply for the open Latarjet as well, where your graft must be adequate. It should be in the inferior sector. It has to be flush with the glenoid articulating surface, and the screws have to have a good alpha angle, which means about 15 to 20 degrees angled, so that you're perpendicular to graft, you ensure graft healing, and you're not messing around with the suprascapular nerve. At the end, because your surfaces are flush, then you've not introduced arthritis to this patient as such. And this is not easy. Whichever Latarjet you do, whether I do a open or arthroscopic, I'm challenged all the time. I think we need the maximum concentration and commitment. These are both not very easy procedures to do as such. This is an example of a 32-year-old epileptic. We had to postpone a surgery twice because she had a seizure the previous day. And so I would rarely ever do surgery for a patient who's not controlled on seizures. Now she has bilateral recurrent dislocation, extensive bone loss. If you look on the right side, she has a AP diameter, which is 23 mm, and on the left side, it's a 16 mm diameter. So that's like an excess of 30% glenoid bone loss. Now, we can't do percentage calculations, but when you're faced with a bilateral situation, we use the normal native measurement of 25 mm, and based on that, we calculate that this is 16 mm, so she's got 9 mm of glenoid bone loss. And that's extensive. And in such a case, in an epileptic, I would prefer to do a Eileck-Kress bone graft, because you can get a larger graft, and in epileptics, because the conjoint is not attached, it's less likely to dislocate if it doesn't heal. If it heals, then it doesn't matter whether you've done a Latarjet or a Edin Hibernate with the Eileck-Kress bone graft. So we've done this for her. Whatever happens, whether you do a Latarjet or ICBG, at between 3 to 6 months, I beseech you to go and get a CT scan, because there is no guarantee that that graft will heal as such. So it is very important that we check, and it's a big learning curve for me also to understand what mistakes I have done. I think there are the last 3 slides left. I know I'm at 15 minutes. These are 3 articles that I would like to refer to you. Number 1, this is JP Warner's article, How to Do an ICBG Graft, and very nicely he's represented how to use the inner table, which is much more smoother. The other tip I would like to share from our practice is this posterior part of the Eileck-Kress should go inferior. So you revert the graft, because then it matches identically. The curvature is actually made for each other. It's a beautiful reconstruction at the end of it. As I said, you must do your CT scans at 3 to 6 months to ensure that there's no screw problem, there's no osteolysis starting up, and the graft has integrated well. A word of caution, this is Palladini's and Poccellini's article, comparison between acute and chronic bony Bankards. Their dislocation rates after surgery were 1 case in each group, but the restoration of function was poorer in the chronic bony Bankard. So they're not the same, because the graft has shrunk. There's not enough meat on the bone. So be careful on those patients, especially if they're athletes and young people. This is the problem that I was alluding to. Unfortunately, we tend to compartmentalize everything into less than 25%, more than 25%, and such. But we are probably addressing, giving a homogeneous answer to a heterogeneous problem. You must factor in ligament laxity, whether it's a male or female, whether it's a contact athlete, and whether there's an associated Hill-Sachs. And based on these, I will come to a decision whether to do a Latarjet. So I have done a Bankart repair for a young intern who's a female, who's not an athlete, and who has had 20% bone loss, and she's doing very well. And there's no harm in doing that. And somebody else would have done a Latarjet, and I don't think there is anything wrong between both our approaches. But it is very important not to compartmentalize everything into a very rigid zone, less than 25 and more than 25. This is a paper from Korea, Incheon, where they compared subcritical bone loss. These are all patients with less than 20% glenoid bone loss. And although they had a reasonably good result, very less failure rate, the recurrence in the Bankart group was almost 23%. The recurrence in the Latarjet group was 6.5%. So there's a difference here. So this is, if you have a young athletic population, then you would err towards doing a Latarjet. And the interesting other finding was that external rotation was more restricted in Bankart than the Latarjet. There's of course a scientific reason for that. In the end, this is a post-Latarjet. If you have an athlete or a contact athlete, they do incredibly well after Latarjet. But all these next 3 slides that I'm showing you, this is a Hind Kesari champion who's achieved his Hind Kesari 3 years after a Bankart repair. The younger guy on the bottom is a national swimmer who's achieved this after doing a Bankart repair. And this is a silver medalist at the Glasgow Commonwealth Games who done a arthroscopic cuff repair and Bankart repair. So let's not get this message home that the Latarjet is the solution to global warming. If there is no bone loss, there should not be a Latarjet. The Bankart is equally adept at restoring function, even in contact athletes. And that's my take. If you find something deficient, if you find there's a associated large hill sacks, then go ahead and complement it with a Remplissage. But don't use Latarjet as a gun to solve all the problems related to instability. It doesn't. So in take home, last slide, bony Bankart to me is a priority. I would treat them. My threshold for operating them is much lower than a Bankart. You must be able to discern a bony Bankart versus a bone loss. Use whatever technique that suits your practice. It doesn't matter whether you do it open. I would say in my first 10 years of practice, I would do all my bony Bankarts open because that was a much robust way of doing it till I honed in my skills. And for the bone loss, you could choose coracoid, ICBG, depending on your practice. But there are a number of patients in the gray zone who are neither black or neither white. In these cases, you need to take a judicious decision based on your skills, based on your experience. Otherwise, take an opinion and then decide. And then you must always confirm post-operatively whether the graft has healed, because a graft that has not healed will have problems, complications, and then you are not appropriate for sending them to their sports. Thank you very much for your patient listening.
Thank you, sir, for a very informative talk. And I have a question for you. You
Yes.
were fixing bony Bankarts. So what is your time limit? Till what time you think of fixing the bony Bankart? You mentioned acute versus chronic. So would you fix chronic Bankarts or you would plan for Latarjet with this?
Good question, Arjoban. If it's a sizable fragment, I would definitely go ahead and do a bony Bankart repair. But if I think that the fragment has shrunk and the combined diameter is less than 25, and it's an athlete and it's a young person, then I might consider doing a Latarjet. If it's a normal person who's a non-athlete, it doesn't matter if he's left with a 3 mm deficit in the glenoid, they would still do well.
Any questions from other panelists? We can take questions for Dr. Joshi's talk as well. So, Dr. Deepak, you were doing when you were doing arthroscopic Bankart, you were using posterior portal as your weaving portal. So, do you always use your posterior portal as your weaving portal, or what is your preferred portal for weaving doing arthroscopic Bankart?
So, actually, this is how we trained ourselves, and this is how I have done. So I go from the superior portal, I look at the labrum, look at the ALPSA or where the labrum is. Mobilization is by looking from the superior portal. Okay. But when I do repair, so that's how I have been trained. So, but when I repair, then I go posteriorly and do it again. So it's just a matter of preference only. But the releasing part has to be done by looking from the superior portal, because then exactly you know where exactly is the labrum and how much you have to mobilize and how much it is required to come in.
That portal gives you the best view.
Yeah.
So any questions from other panelists?
Deepak, just you said you used to use knotless anchors, but you don't use them anymore. Any particular reason? The reason I ask this question is that I've used the same knotless anchors for last 13 years and I've not changed my technique at all. And so why did you started knotted, then you moved knotless, and then you back to knotted? Why?
It just that sometimes the anchor used to come out, and it's just a feel that, because when you put a knot on it, it's a feel that, okay, the thing is secure. That always used to lack when I used to put a knotless anchor. That is the only reason. Otherwise, as far as the result wise is concerned, all the patients, I think, probably are doing better as. Then we visited, I think, Barkard, I think Dr. Chaudhary. Then after that, I visited. So we then, from his philosophy, the first anchor has to be the knotted, the lowermost anchor. So when we visited, after that, we really changed completely. Now we very less often that we use a knotted and a knotless anchor. So it's not as far as the results are concerned, nothing. I don't think there was much difference. And it's just that we feel secure when we put a knot, that the tissue is coming and creating a bump.
So I have never used a knotless anchor. So I can ask you people that, can you get the same amount of bumper effect which you get with a knotted anchor?
Yeah, exactly. So it's very good. So if you take a bite, and you have seen this, the anchor that I had shown in my feed, you get almost the same bumper if you take a good bite. But it's just a feel. I have seen a person, because I visited Dr. Martin, I think, in Holland. He always put knotless anchor. So after putting the knotless, doing the repair, he used to take out the scope and he used to do full ABR. And then he used to go inside again and see whether anything is ruptured or the anchor is getting. He used to show us that how good knotless anchor are there. They're nothing, they don't get loose. It's just that we stopped doing it, and we are happy with the knotted ones.
It's interesting, Shekhar, that when you use a knotless anchor, once you've taken your first bite as low as possible, you get it. If you're using a knotless anchor, you can actually pull it to wherever you want. So you're not bound by the position of your first anchor that you put at 5:30. Let's say you take an inferior bite and you want to pull it up, and that capsule then shifts to, let's say, even 4 o'clock. Just do that, and then you can reinforce 2 more anchors below that, and that helps. So I've always felt that using a knotted anchor actually is counterintuitive, because you're now determined by your post position. While if you're doing a knotless, you can pull your post to wherever you want to, and that gives you a better shift. And as far as your bumper, in my talk, there is a little video, but you can get a very good bumper. And Harjobhan will testify that when he was with us, that's all we used to do, always done a knotless anchor, and never repented that. And I've always worried about the knot stack as well. I know all the knotted guys will tell me that they try and put the knot medially, which is away from the articular surface. But I don't know what happens when the water gets out of the joint. Where does that knot stack then sit, is the other worry that I've always had. So, but that's a philosophy. And as I said, I've not repented using knotless anchors, and that's what I've always done.
But we can get the same effect if we take the bite first and then we put the anchor. Like, we use a shuttle technique. So we first take the bite to the capsule and the labrum, and then based on the position of the bite, we put our anchors. So that also you can get the same effect here.
I'm sure it is what you're used to, and I said, but the answer to your question was, I think we can get a
equally well
shift and a good bumper with knotless anchors as well. Especially now the tapes are there. So with the labral tape, you get a broader area of contact, and that's much kinder to tissues, and there is less friction. There is more friction in that as well. So that's actually quite a good advance as well.
I think we can move on to the next talk of Dr. Shekhar Srivastava. So you can share your screen.
Yeah. Okay. So we have discussed that how bony defects matter a lot in shoulder instability. So management of shoulder instability is not just Bankart repair, but Bankart repair plays a very good role, very important role in management of anterior shoulder instability. Now, when the arm is by the side of your shoulder, then the stability is usually provided by the negative intra-articular pressure. And in the mid-range, it is the concavity compression effect which is providing the stability. The ligaments and the capsule are important for the end-range stability. Now, why does bone loss occur? Now, it can be because of avulsion. So there can be an avulsion of a bone piece along with the labrum. There can be attritional glenoid bone loss because of repeated dislocation. And on the humeral side, you get Hill-Sachs lesion. So Hill-Sachs lesion is basically a posterior defect in the humeral head. So when the head dislocates and the posterior part of the head, it bangs against the anterior border of the glenoid, which is quite hard and sclerotic, and that creates an impression. So Hill-Sachs lesion is supposed to be present in almost 65% of the patients after first dislocation, and it is reported to be present in almost 100% of the cases with recurrent dislocation. Now, why does bone loss matter? We have been hearing this again and again in all the previous talks, that though arthroscopic Bankart repair very good results, but still the failure rate are almost in the range of 10 to 15%. Okay. And the major cause of this failure is poor selection of patients. That is failure to assess the bone loss. So if there is a bone loss, then whatever good technique you follow, it's going to fail. So here you can see that when the arm is in full abduction and external rotation, the capsule and ligaments, they become tight, and that is the primary stabilizing force. Now, if there is a glenoid bone loss and you have done a Bankart repair and the arm is in full abduction, the end range, the capsule still remains tight and it will hold the head. But in mid-flexion, when the capsule becomes lax, then the head falls into this pouch. So that puts stress on your big repair and slowly it stretches out. Now, similarly, what happens in Hill-Sachs lesion? Now, when your arm is in abduction and external rotation, then the posterior part of the head is supported by anterior part of the glenoid. Now, if this Hill-Sachs lesion is small and a part of the head is still supported by the glenoid, then your Bankart repair will stay. It's going to be successful. But if your Hill-Sachs lesion is large, then even after repair, it is not supported by the glenoid. The head is not supported by the glenoid. So then it engages into the glenoid, and it engages into the anterior part of the glenoid. This again stretches your repair and it will lead to failure. So whatever good repair you do, however good repair you do, if your bone loss is big enough, then it's going to stretch upon your soft tissue and it's going to fail. So you cannot say that I had a bony lesion, but I did a very good repair, very strong bumper. No, it may hold on for some time, but slowly as the head engages into the glenoid, it will stretch your repair and it's going to fail. Now, most of the failure which we talk about doesn't happen immediately. If you follow a patient for 5 to 10 years, then you will actually know the failure rate of Bankart. Now, these bony lesions, they don't occur in isolation. So it's not that you will just have a glenoid bone defect or a Hill-Sachs lesion. Usually there is a bipolar defect. So there will be a Hill-Sachs lesion, and then there will be a glenoid lesion as well. So when you assess whether your Hill-Sachs lesion is significant or not, then you have to keep both in mind: the amount of Hill-Sachs lesion, or the degree of Hill-Sachs lesion, and the degree of glenoid bone loss. Now, initially there was this method of dynamic assessment where the Hill-Sachs lesion was assessed intraoperatively while doing arthroscopy. The arm was taken into abduction and external rotation, and we used to see whether the lesion is engaging, the Hill-Sachs lesion is engaging into the glenoid or not. But if you haven't repaired your Bankart, then there is no constraint to prevent this Hill-Sachs lesion engaging the glenoid. Okay, so if you want to really assess whether this Hill-Sachs is engaging or not, then it has to be assessed after Bankart repair. Okay, now many of us are doing this surgery in lateral position, so then it becomes quite problematic to do abduction and external rotation in this position. And secondly, you are always apprehensive that you may damage the repair, you may stretch out the repair. So the most important thing, or the thing which has to be done to assess the glenoid bone loss, is to do it preoperatively. So we have discussed about the glenoid track technique, which was explained by Dr. Harjovan. So that's very important to assess that whether your Hill-Sachs lesion is significant or not. So normally in abduction and external rotation, the posterior superior part of the head articulates against this part of the glenoid. Now, if your let's come here. So you draw this glenoid track on the posterior superior part of the head. Now, if your Hill-Sachs lesion is within the glenoid track, then you can just do the Bankart repair. You don't have to address the Hill-Sachs lesion. Okay. If your Hill-Sachs lesion is beyond the glenoid track, that means it is off track, then you have to address the Hill-Sachs lesion. Now, how to draw this glenoid track? That you have to again go through the literature and study. It takes into account both the defect in the head of the humerus as well as defect in the glenoid. So by doing that on CT scan preoperatively, you can assess whether your Hill-Sachs lesion is within the glenoid tract. If it is within the glenoid tract, then it is known as on-track lesion. If it's an on-track Hill-Sachs lesion, then you don't have to address it. You can leave it as such, and only your Bankart repair will be okay. Now, if your Hill-Sachs lesion is beyond the glenoid tract, then it becomes off track, and that needs to be addressed. So based on that, you can divide it into 4 groups. Now, if the glenoid defect is less than 25%, then you can just do Bankart repair. If the Hill-Sachs lesion is on track, Bankart repair alone is enough. If the Hill-Sachs lesion is off track, you have to add Rempisage to the Bankart. And if the glenoid defect is more than 25%, then the Bankart repair is not going to work, and you have to do some bony procedure like Latarjet. And if you have such a big Hill-Sachs lesion that even after doing Latarjet, it is off track, then you have to add some other humeral procedures, like you have to do either bone grafting procedure or some other thing. So if we talk about the management of humeral head bone defect, if the Hill-Sachs lesion is small, it is on track, it doesn't require any treatment. Okay. Or imagine a situation where there is also a glenoid bone defect and you are doing a Latarjet for that. Now, if you have done a Latarjet, then you have effectively increased the arc. Okay. Now, as you have increased the arc, so the glenoid arc also increases, and probably an off-track Hill-Sachs lesion has now become on-track. So in that case also, you don't need to do anything. So if you have done a Latarjet, probably this lesion has now become on-track and it doesn't require any treatment. But in an off-track Hill-Sachs lesion, you can fill it up either with a soft tissue, which is usually capsulomuscular, the infraspinatus and the capsule that is used to fill up the defect, that is known as remplissage. It can be done by open technique, but mostly it is done arthroscopic. If the defect is very large, more than 35% to 40%, and if you try to fill that up with a soft tissue, then you are going to constrain the shoulder. Then the movements become quite restricted. So in those cases, you have to do some open procedure. You can fill them up with osteochondral bone allografts, or you can do derotation osteotomies, or even sectoral resurfacing or hemiarthroplasty. Now, there's also a new technique of disimpacting this bone which has depressed. So you make a cortical window here, and then you, with a bone tamp, you just disimpact and bring it back. That can be done only in acute cases, and then you fill it up with some bone graft and a screw. So remplissage is filling the defect with postero-superior capsule and infraspinatus. So that makes the defect extracapsular. So you see, this is a very big defect. The defect is extending quite medially. It's not the depth of the defect which is important, it's the extent of the defect. If the defect is extending more medially, that means there's more possibility that it is an off-track lesion. So again, a big Hill-Sachs lesion. Now here you can see it's a narrow Hill-Sachs lesion, but it is away from the attachment of the cuff. So again, this is a significant Hill-Sachs lesion. And once you do the remplissage, then you fill up the defect and you can't see the defect. This is a small video demonstration of doing remplissage. So, so we are operating on a left shoulder. This is the anterior glenoid margin, humeral head, and this is the posterior, and our scope is on the anterosuperior portal. And you can see the extent of the Hill-Sachs lesion. Okay. Normally one anchor is enough, but if you have a big lesion like this, then you need to use 2 anchors. So the first thing is that you do diagnostic arthroscopy. You see the position of the labrum. If you want to release them, you can do that. Then you come back to the Hill-Sachs lesion. You decorticate it with the help of a burr or a shaver or a rasp. You want the tissues to heal to the lesion. So you want to make them rough, and you want a bleeding surface. Then from the posterolateral portal, you put the anchors. Now this is coming through the cannula. You took, so these are 2 5.5 anchors. Now after that, what we do, we retract the cannula into the subacromial space, and then with the help of these penetrators, we take mattress bite through the capsule and the infraspinatus muscle. Now, so after taking the bite through these tissues, you leave them as such and come back to your Bankart repair. Once you have completed your Bankart repair, then you tie those sutures. So that is done blindly, and the knots are in the subacromial space. So you can see that the whole defect is now filled up with the tissue. This defect has now become extracapsular and it doesn't engage us. So the clinical results have shown good result with remplissage, and imaging studies have shown successful muscular capsular tenodesis in almost 75% of the cases. Various studies have shown the importance of remplissage in treating the off-track lesions. Especially, I was going through the paper by Dr. Vivek Pandey, and where he compared treating off-track lesions with Bankart alone and with remplissage. And there were significantly fewer redislocations in patients with off-track lesions who underwent Bankart repair and remplissage than in those who did not undergo remplissage. Now, in their study, they found that there was a restriction of movement of around 3 to 4 degrees, which was statistically significant, but functionally they didn't find it to be very important. Now, if your lesion is big, then as I explained earlier, that you can't do remplissage because then you will be really over-constraining the joint. So in that case, you have to do open procedure. You can either fill up the defect with an osteochondral allograft. So it's an open technique where you go by deltopectoral approach. Then you externally rotate the shoulder so that the defect comes in front, and then you fix it with headless screws. Or you can do derotation osteotomy. So I don't have any personal experience of this, but here you basically try to derotate so that the lesion goes more posterior and it doesn't engages when the arm is externally rotated. Now, there has been a systematic review which compares all the humeral procedures, the remplissage, humeral osteochondral graft, Weber osteotomy, and shoulder arthroplasty for management of humeral bone defect. And their conclusion was that the arthroscopic remplissage is the safest technique for management of patients with shoulder instability with humeral bone loss. It is associated with lower rate of recurrence when compared with Bankart repair alone. And Weber osteotomy, humeral allograft reconstructions, shoulder arthroplasty, and hemiarthroplasty are characterized by high rate of recurrence, complication, and poor outcome scores. But that is understandable because these techniques are done in those patients where the defect is quite large. So to conclude, bony defects, to recognize bony defects in a shoulder instability patient is very important. It's very important to preoperatively recognize whether your Hill-Sachs lesion is on track or off track, okay? Because accordingly, your treatment plan is going to change. Various studies have shown that failure to address off-track Hill-Sachs lesion can cause increased redislocation rates, and Bankart remplissage is an effective procedure to reduce redislocation rates for off-track lesions. Thank you.
Thank you, sir, for the nice presentation. I think that has cleared all the doubts about addressing Hill-Sachs lesion. Now I invite Dr. Kapil Kumar to share his screen and start the next. While sir is sharing the screen, sir, can I ask a question? Which part of Hill-Sachs do you put your anchor in? The medial part or depth of the Hill-Sachs or the... So you have to unmute.
Yes, Arjuman. If the Hill-Sachs is extending very medially, normally I would like to put my anchors close to the articular cartilage. But if the Hill-Sachs is extending quite medially, and if you put it close to the articular cartilage, that means you are putting your anchor very medially, and you are taking a lot of bite through the tissue, then it might restrict the motion. So in those cases, I go in the center, but mostly I try to put it along the margin, along the articular margin.
Over to you, Kapil sir. So you can start your presentation.
Thanks very much, Harjuman. Thanks for the invitation, Shekhar. I think a lot of things have been talked about in the previous talks, and from the initial evaluation to addressing the bony defects and the importance of surgical technique by Deepak as well. So I'm trying to go and bring them together. I know I was supposed to talk about challenges of revision shoulder stabilization, but I think the challenges are more in evaluating why the initial stabilization surgery has failed, because unless you identify the problem, you really can't find a solution to that. So I'm going to try and see what are the causes of failed shoulder stabilization, and I'm going to focus on arthroscopic procedures. I'm not going to go into the realms of failed lateral J procedures because that's a talk in itself. And how do I evaluate? And then I'm going to bring some cases in which have failed. Some of them are mine, some of them are sent to me. And we can have a discussion about what caused the initial surgery to fail. Was there something that we could have changed in our decision making or management? And how do we go forward? Okay. So first, I'm going to start with the basics. What ensures shoulder stability? And we have learned that it's the capsulolabral complex, which is the stabilizer of the shoulder. We know that an effective functioning rotator cuff is quite important for shoulder stability. We have learned from Ashish and Shekhar's talks about the area of contact between the humeral head and the glenoid. So if there's a bone loss there. But I think one bit that is missing is which we often overlook, is the incorporation of the muscles. How are the rest of the periscapular muscles working? And hence I'll draw your attention to this Stanmore triangle. What we've been talking all about is the polar type 1, which is the traumatic structural instability. But there's a huge group of the atraumatic structural instabilities, especially the young adolescent teenage girls who are double jointed, who come to you with symptoms of instability. They feel their shoulders coming out, but they may never have had a true dislocation. And then lastly is what is poorly understood amongst most of these surgeons is the non-structural muscle patterning groups, where it is probably a muscle dysfunction of scapular stability and the other muscles, which leads to this symptoms of stability. And hence, it's very important to recognize that the type 2s and type 3s may be the contributors to your failed surgery, where you did everything right, but you have got a failure in front of you. So we're going to try and bring these things together. And we know, we have seen excellent technique shown by Deepak about what is the aim of surgery in arthroscopic surgery. The aim is to restore the capsulolabral complex at the front, create this soft tissue bumper here. You want to address any concomitant rotator cuff pathology. And you want to address the bony defects, and then you want to rehab the patient. And that is if you do all these steps correctly, you are likely to get to a successful situation. And we know that Harjoman has told us that the numbers of arthroscopic stabilizations are going up. All of us have now got reasonably good arthroscopic skills to do this procedure. We have seen a huge development in techniques, anchors. The anchors are getting smaller. The sutures are getting stronger, from sutures to tapes and etc. We're still doing that. And I think our success rates are improving. But still, if you look at the literature, you've got failure rates of up to about 3 to 25%, depending on which series you look at. And why are these failure rates happening? Why are we still failing with these procedures? So it's like a recipe book. You open a book or a cookbook, and you've got the ingredients. So what are the ingredients that we have got which look at how to get, if I had to write a cook recipe for how to achieve a successful stabilization procedure. So what have we got? We've got a patient, we've got the surgeon, and we've got everything else, which is your implants, your anchors, your sutures, and your technique. And it's a combination, it's the ideal combination of these things that will enable us to achieve a successful outcome. So let's look at what goes wrong where. So who is your right patient? We've listened to various evidence from the literature as to who is your at-risk patient. We know that if you're a younger man, if you have a more number of dislocations, if you've had high energy injury, then you're at a higher risk of failure. It's still unpublished, but there is work from Wrightington Hospital from Len Funk's group, and they have looked at adolescent patients with undergoing stabilization and then returning to recovery. Their failure rates are about 80%. So imagine that 8 out of 10 patients, you are doing an arthroscopic procedure, they're failing within 12 to 24 months because it's that age, it's the sport they're playing. Are we doing the right procedure? Have we missed something? Did we miss a Hagel lesion? Did we have a patient who was inherently lax, and we have not addressed that capsular laxity? Remember, your arthroscopic procedure is not just about stitching your Bankart back. As Deepak told us, you have to tighten the ligament. You have to restore the proprioception. We've heard from Ashish and Shekhar about addressing the missing bony defect. And then, are we doing the right person? Is it a pilot error? Have we done something wrong? Have we used the number of anchors that we were supposed to use? Have we put them in the right place? Did we have, if we were using a knotted configuration, was our knot robust enough? We heard somebody say that after the operation, they would put their patient through a full range of movement. Do we have the conviction and courage to do that? Or we are too scared and we say, right, we'll put them in a sling for 6 weeks and it'll all be fine. So you have to go through things as to why your stability surgery is failing. We've talked about these patient factors. Younger the patient, their competitiveness, and Harjavan told us about the instability severity index score, Pascal-Boullou. So again, think about these things when you're assessing a patient with failed stabilization. I'll skip over this. This is again addressing the same issues, but there is a number of papers which tell you that if you've got a younger patient who's got a high energy injury, who's had multiple dislocations or needed to be reduced prior to their operation, then the revision procedures then your surgery is likely to fail, and there's a high risk of failure. And this is very important here. Is this the right patient? That this is a girl who's sitting there with her shoulders subluxed anteriorly. And I'm going to talk about her in my case discussions later on. Is this the right person to go and do an arthroscopic procedure? This girl can dislocate her shoulder voluntarily. Should you be fixing on this person? Should you be operating on this person? Or is this person best served by something else? So again, you go and operate on these, you have got a high risk of failure. So think about it. So what do I do when I've got to evaluate a patient who's come to me with having failed a previous stabilization procedure? Who is this patient in front of me? What's their age? What's their gender? But I really want to know from their history, what was the episode or what were the circumstances around the first dislocation they had? What magnitude of force went through their shoulder at the time of the first injury? How many dislocations did they have prior to getting their primary surgery? How reducible have their dislocations been? Have they just come out and gone back in? Or have they had to have them reduced every time that this happened? Then you want to know who was the surgeon who did the operation? What was this operation? Was it open? Was it arthroscopic? If at all, try and get all the data from that surgeon. Or if you did yourself, go back and look at your notes. How good was the tissue? How many anchors did you use? Did you record the video or did you record any images? Look at them. Was there subsequent trauma? And this is all a part of your clinical evaluation. We haven't done any complex investigations, and this gives you a lot of information before you decide to investigate them with further imaging. Then you start examining them. You want to see what's their range of motion. Are they apprehensive even putting their arm in slight abduction, external rotation? Where is this apprehension? Is it high arc? Is it mid arc? Is it low arc? What's their cuff strength? Okay, good. This man came to us because he felt his shoulder was loose. He does not have a structural problem. He's got a poor muscle control. Watch his scapula. If this is not a person who has had stabilization surgery, but he was sent to us as an unstable shoulder. If you operate on him, you're doomed. Look at if they've got inferior capsular laxity. This is the Gagey sign here. If you've got more than 20 degrees difference between the two signs, they've got inferior capsular laxity. Look for other signs of laxity. Look at the sulcus. Look at their Baton score. And then you go to imaging, and we have discussed this, radiograph, CT scan, and there was a question about MR or MR arthrogram. In my practice, I do MR arthrograms. If you've got good radiology, good MRI scan, or you don't have access to MR arthrogram, then you can do an MRI scan. But these are the investigations in that order that I will do for somebody who has had a failed instability surgery. Because we have heard in all the talks this morning that unrecognized bony defects are a biggest cause of failed stabilization surgery. And I'm not going to dwell on the track and the glenoid bone loss and Hill-Sachs defect and the size, etc., because we have done that in great detail. And then finally, you can have a look at arthroscopy. Now, this patient has had previous surgery because arthroscopy lets you look at what is the quality of tissue that you're looking at. Where is the anchors that have been put in? Is there a technical error that's been put in? Are the anchors too high? Are the anchors too medial? Is there any unrecognized bone loss? And is there cartilage damage? So you want to do all of that, and you want to do a good arthroscopic evaluation, because till you've done that, you really can't solve the problem. So I'll just go on to some of the cases. This is a 32-year-old man who about 3 weeks ago presented to our emergency department with this injury. Now, on this lateral view, which is a beautiful en-face view of the glenoid, you can see that there is a little bit of glenoid bone loss here. Now, this man has had stabilization surgery done by me in 2011. Okay, this was his CT scan prior to his index operation. He had a small Hill-Sachs. There was no glenoid bone loss. When we scoped him, this was a non-engaging bone defect, and I stabilized him with 3 Nautilus anchors in 2011. He's at a fall now, and now he has got a dislocation. So now the question that and this is his x-ray now. So obviously there is a bit of glenoid bone loss, and we heard from Ashish Babulkar telling us that you can have fractures through where your anchor holes were. This is now a chronic situation. It's 10 years down, nearly 10 years down the line. So the question here is it just a consequence of new trauma? Was that initial bone loss, which I dealt with soft tissue procedures, was that Hill-Sachs significant enough that I should have added remplissage? 10 years ago, I was not doing remplissages. Can I just blame all this on the new trauma? And now what? And I'm going to leave it open. Yes, I will get a CT scan. Yes, I will get an MR arthrogram. Now what? Should I do another soft tissue procedure? Or because he's got new glenoid bone loss here, I should go for a bony procedure like a lateral J? And those are the questions that you have to think when this is a relatively simple case. He's had been operated for 10 years. Things are easy. So he's still, because he's an NHS patient, he's waiting for a CT scan, which should be done soon, and then we'll plan his management. So I'll move on to another one now. This is a 22-year-old man, and in 2014, he came to us with recurrent instability. His first injury was playing rugby, for which he needed a manipulation under anesthetic. He had further episodes of dislocations, and when we scanned him, he had an anterior labral lesion, and he had a posterior labral lesion. And he had a Hill-Sachs. There was no glenoid bone loss. I'll just pause here for a second and take a straw poll between Shekhar, Deepak, and Harjaban. What would you have done in 2014 for this man? He's a high energy injury. He's got no glenoid bone loss, and he's got a soft tissue injury and a Hill-Sachs. I'll open the floor and I'll take your options.
I think 2014 was a time when we were not doing remplissage that much, so I would have gone for a simple soft tissue Bengkalt repair in this.
Okay, Shekhar?
So you have to unmute.
Soft tissue stabilization, both anterior and posterior.
Okay. And maybe Harjavan, you were here at that time. Maybe we did it. So anyway, I did an arthroscopic procedure on him, and I find an extensive labral tear. He had a type 4 slap. So I had 3 anterior and 2 posterior Nautilus anchors, because that's what I've always done. And initially he was fine. But 2 years is not the time when you say your arthroscopic stabilization has been a success or a failure. So 2 years later, he went back playing rugby, and he dislocated his shoulder again. He had fresh injury. At that time, this guy had moved from Aberdeen to Glasgow, and he underwent another MR arthrogram in Glasgow. Surprisingly, they didn't do any CT scans there. You can see my anchor, the posterior anchor here. You've got work on the anterior side. So now he's dislocated again 2 years later. Unfortunately, as I said, they did not do any CT scans. So again, Shekhar, what would you do for him now?
So on this MRI, still there is no bony lesion. There is no bony defect. And if the labral quality is good, then I would go for refixation, Bankert again.
He's got 5 anchors already in his glenoid rim. Where are you going to put your other anchors? I can say that I didn't put the anchors. I don't put anchors above 2 o'clock on the glenoid, so all the anchors are below.
Yeah.
So that is a challenge now, isn't it? Where will you put your anchors?
Yeah.
Deepak?
I think I will go for a bony procedure in this Latarjet. That is what we follow in our scenario where we have lots of wrestlers coming with us. So the first surgery is always a soft tissue procedure. We try to do that. But the second one, I really, in these patients, in the professional rugby player, I tend to do a Latarjet in these cases.
Harjavan?
I would think of doing a Latarjet as well, sir.
Yeah.
Since he has high chance of dislocating after a Bankert repair again.
So anyway, so in 2016 in Glasgow, and this is a very good surgeon in Glasgow, he did a further arthroscopic stabilization. Unfortunately, I could not get access to his records. So I don't know where he put anchors, how many anchors did he put. So now, 4 years later, he fell again outside a swimming pool and he has got an anterior dislocation. And these are his investigations now. So you can see there are multiple holes in the glenoid from where our anchors have been. He has got a Hill-Sachs lesion, which is actually quite high, which is again a worrying thing, because the higher the location of a Hill-Sachs, that's more worrying. And that is why if you go back to the instability severity index score, the Hill-Sachs being visible on an external rotation X-ray views, that means the Hill-Sachs is higher, more superior, and that's a higher risk factor. So again, what I'm trying to come to here is that if I go back to the 2015 scans, we agreed that there was a Hill-Sachs, but there was no glenoid bone loss, and probably that was the right operation to do. In 2016, should he have had a Latarjet after repeat dislocation, considering somebody's playing rugby, still young? Now, the issue is, I don't think there's a position place for soft tissue procedure now, and we'll all agree that we'll do a Latarjet now. Would everybody agree?
Yes.
So then, Shekhar, the point is, he's had so many anchors in his glenoid. So when you will go and do a Latarjet, are you worried about those anchor positions and potential weakness in the glenoid with all those anchor holes? Or you're not worried about that at all? Considering that I can tell you the anchors that I use are all PEEK, and I know that the guy in Glasgow who did this operation, he does exactly the same as I do. So he would have put further PEEK anchors in it. So now he's got about 5 or 6 or 7 PEEK anchors in his glenoid. Are you now worried about how to play? Where would your fixation of your Latarjet graft?
So I would like to go ahead and try to do the normal Latarjet. You can drill through the PEEK anchors, and the screws which we are using, they have to get a good hold on the opposite cortex. So that is, I think that is quite okay. You have done in this case, you have done posterior labral repair also.
Yeah.
But those were 2 anchors, and it's almost 6-7 years now. So I think if we get a good purchase in the posterior cortex of the glenoid, then that should not be a problem.
Okay. So now I'll come to this one. Now this girl, she's about, I think 16 or 17 now. And when I met her, she was about 14 or 15, and she had no problem with her shoulder. She used to do gymnastics at school. And one day, while she was on I think one of the vaulting horse or whatever, she fell and she injured her shoulder. And this is how she presented to the emergency department. Her shoulder was subluxed. You can see it's antero-inferiorly subluxed. So this was a first-time dislocation with no previous shoulder problems. And she was taken to theater by the trainees. They attempted to reduce it, but every time they put it back, it came out again. Even as soon as she woke up after the anesthetic, the shoulder was out in the recovery room. So this is when I saw her. It's interesting. The reason I haven't put her plain radiographs is that none of the plain radiographs show her shoulder to be dislocated. But we arrange an MRI scan and you can see the shoulder is not dislocated, but it's subluxed. It's just sitting at the edge, but not quite out. And she had about 4 attempts. So I saw her about 10 days after initial injury. This was her state. So what would you do at this stage? Deepak?
Definitely, we have to evaluate. I think you got an MRI done, and what were the findings on an MRI?
We could not see any. Obvious labral tear. The cuff was intact, and this is what you see on that.
And what about the ligaments? The ligaments were fine.
Yeah, they were all fine. Yeah.
Yeah. So I think these are one of the very difficult scenario. But since she is there, if we take an history and she was absolutely fine, I think then probably there is some capsular laxity associated with it. But definitely, if it is not reducing, we have to plan and probably go inside and see what is happening.
Okay, I'm glad you say that, because this is what I did. So I went and did an arthroscopy. I did an EUA, and you could sublux the shoulder anteroinferiorly. It was not multidirectional. It was not going posteriorly. A dry tooth test was positive, and there was no obvious labral lesion. But I felt that there was maybe a small rent. This is the anteroinferior capsule. I do have all my operations in beach chair position. So viewing through the posterior portal, I thought there was a little rent in the inferior capsule, which was a bit baggy. So I did my standard technique. I did an inferior capsular plication and shift. I put one anchor in because she was only 14, 15. After my one anchor, her drive-through was abolished. I did an EU again. I could not sublux it. So I decided that because she's so young, I will not put more anchors in, and I just left it at one anchor. I kept her in a sling for about 4 to 6 weeks' time, and then we rehabbed her, and she was fine. For 18 months, she did fine, and then she started coming back to our emergency department with further episodes of the shoulder subluxing. So, what do you do now?
And she has been undergoing muscle training and everything.
Yeah, so she was doing rehab for those 18 months and everything seemed to be fine. But now she's subluxing. She's now 2 years. So essentially from the initial operation, she's about 4 years down the line. And now what she's gone in, if I go back to that Stanmore triangle, so I think she was in a traumatic episode based on an atraumatic. So it was type 1 over type 2. But now she has got severe muscle patterning. She can hardly even elevate her arm above 90 degrees. So she's been going intensive face-to-face physio for last 6 months. And now we can barely manage that she can elevate her arm above 90 degrees. The moment you stabilize her scapula, you lie on her bed, she's got full movements, but now she's got severe muscle patterning superimposed with that. So the reason to bring this case is that what started with a trivial traumatic injury with the shoulder that was persistently subluxed in somebody who had no previous shoulder problem. And in hindsight, I don't know whether I did the right thing by operating on her in the first instance. Maybe I should have persisted with more physio. My physio tells me that she's got very hyperactive pec major. I have tried to give a Botox injection to her pec, which seemed to stabilize for a while, but it's come out again. So the reason to discuss this case is that things are not always straightforward as we think. She has got a lot of psychological issues, which we have now unraveled. So things have not been right from the day one. And maybe my first operation was not the right one. The question now that I pose to you is, would you now, her shoulder is still subluxing, she's got poor proprioception, would you operate on her now?
No, I don't think so. I think this is the time. These are the patients who come to us, and I don't think that they will do well with surgery. They will keep on telling you, they will keep on going here and there, and somebody advises them, okay, go for surgery, we'll do a re-surgery. I think these are the patients we would not like to put a knife again, and we should try to do some psychological counseling and a rehab, basically a strengthening only program.
That's where we are. So as I said, she was probably somewhere here when she dislocated, but now she's coming in this area here, which she was muscle patterning, non-structural, and she's now come here. So so again, this was a different failure, but it is again one of my cases which has failed, and I thought I'll discuss it with you. I'll just go to another. This is probably, I'll finish after this case, although I've got a few others, but I'll probably just finish after this case because it is not always the patient's fault that they've got a dislocation, that their surgery has failed. So this is a 19-year-old boy who had recurrent posterior instability. I know I was supposed to talk about anterior instability, but he was sent to me with query recurrent posterior instability. He had seen another surgeon in another hospital who had done an open procedure for his posterior instability because he does not do arthroscopic work, and he had done an open stabilization. Now, if you look at the plain X-ray here, there are two metal anchors which are very high. They are in the upper quadrant of the glenoid here. This is a CT scan. This anchor is far too medial. And when I scoped him, you can see I'm viewing through the posterior portal, so his anchors are very high, but they have missed because they did it open, they missed out an inferior labral lesion. This labrum is not normal, and they also missed an anterior labral lesion, which is there. So this was a technical error. This is a pilot error, which has led to the crash here. So they have missed because they did not do proper imaging, and they just went based upon the fact that he was feeling his shoulder come out posteriorly. They opened him through the back. They never assessed the rest of the labrum, and they put two anchors which were too high. And as you can see, I'll play this video again. There is evidence of chondral damage because the anchors are too medial. The labrum is not healed. There is labral pathology inferiorly as well. So you can't blame the patient always for the failure. So that brings us to the fact that so in this patient, the anterior lesion was missed, the labrum was poor, the anchors were very high and very medial, and there was chondral damage. But we mobilized the whole labrum. We've done both anterior and posterior repair. We did them in November last year. So I will not tell you whether it's a success or failure, because to quantify or to qualify something as a success or failure less than 2 years after stability surgery is completely naive. So I will not say that to you. But the reason I brought this case was that it is not always a second trauma. The poor surgery technique is very important contributor to the failure. So do we have time to discuss one last case, Harjuman?
Yes, sir, we can do that.
Okay, so this is an interesting first. So this is a guy who's 34 now. Aberdeen has got a lot of offshore oil industry. So his job involves abseiling down the sides of offshore rigs. So essentially he's hanging down from ropes working on these. There are 4 dislocations before I did an anterior stabilization and remplissage in 2013. He returned back to work, which was obviously high energy, hanging down these ropes. In 2018, so 5 years after the first operation, he was in the gym and he was lying on a bench doing some free weights when he felt the weight would just sort of roll off, and he suddenly put his arm into abduction extension to catch this weight and shoulder dislocated. And this is his X-ray following that. So this is his, and this anchor that you see here is a remplissage anchor, and I'll show it to you in a second. So that's his CT scan now. There may be a little bit of anterior glenoid bone loss, which wasn't there to start with. This is the anchor in the remplissage, and this is its MR arthrogram after the remplissage. Obviously, there's a bit of sort of scattered because of the metal anchor, but the posterior capsular remplissage seems to have healed. The cuff is right into the defect. It's not lifted off, but he's now failed. So the question here is, did he have bipolar bone loss, which I tried to fix with the remplissage, and maybe I should have done a Latarjet to start with? The issues now are, there is an anchor in the humeral head which we can disregard and probably do a Latarjet. But going back here, this was the initial glenoid bone loss. Would anyone have done a Latarjet and not a remplissage at this? Or am I just unfortunate that this has dislocated 5 years after the initial operation? Comments and criticisms from all of you.
I think the initial procedure was, I think it was all right. I think with this much of bone loss, we definitely will go for a Bankart and a remplissage on first stage. But I think he had a significant injury. What you are telling is, I think the injury was significant to have a redislocation again in such case. And again, a heavy worker, second time, I will always look for going for a Latarjet now.
I totally agree, sir. It's still not an inverted pear shape, though there's anterior glenoid bone loss, but still, I agree with Dr. Deepak that I would have also done the same thing.
That's reassuring. Yeah, the answer is simple. We'll do a Latarjet now, but it's not the solution. What I want to try to bring these cases to analyze why the initial operation failed, and if anything, we could have done anything better. So to bring it all together, I think there is still, in my opinion, an unacceptable failure rate after arthroscopic stabilization in some series, but the causes are multifactorial, and we have to pay a lot of attention to evaluation of patient prior to the index operation. Make sure that you have ruled out any underlying ligamentous laxity, any muscle patterning. And when you're confronted with a failed stabilization operation, get all the history, details of previous surgery, patient's medical problems. One thing that I haven't spoken about, which was spoken briefly by somebody else, was epilepsy. Have they got any underlying seizures? And then you investigate to identify your soft tissue lesions and your bony defect. And then the management for each case is tailored to the specific patient. There's not a recipe book which you can follow, but if you follow the principles, A, you will reduce your failure rates, and B, you'll have a structured approach to address your when you're confronted with a patient with a failed procedure. Thanks very much.
Thank you, sir. I think you have cleared. I wanted to ask you one thing, but I think you have already answered that within the presentation only.
Go and ask it again.
So I wanted to ask whether your procedure of choice for the failed surgeries, failed cases, is still, you have a pre-op decided that this is a arthroscopic revision Bankart you should consider in this patient, or you would straight away plan for Latarjet? But I think that is...
I think the issue there is that if I've done the operation myself and that has failed, but still there is no significant bone loss, then I think that in that case, I made a decision that doing a repeat soft tissue procedure is not going to be helpful. However, if the patient comes from somewhere, especially the surgeon I know is maybe not a very good arthroscopist, but they've attempted arthroscopic surgery, and I don't have bone loss documented on my pre-op investigations, then I will probably try an arthroscopy and evaluate the soft tissue. And if they're repairable, again, I'll do that. But sometimes you go in and the soft tissue quality is not good. The thing that I tell a lot of my patients is that doing pre-op scans is like internet shopping. You can see what you're getting, but it's only the quality is when the thing comes into your hand. That's when you go and do an arthroscopy, you discover that the labrum or the capsule is poor and you really can't pass any sutures or the sutures cut through. There's no point in doing that. If the raw material you're dealing with is not good enough, there's no point in doing a soft tissue procedure.
Anyone from the panelists has any other question? Shekhar sir or Deepak Doshi sir?
Yeah, Dr. Kapil, that case of 19-year-old girl which you showed. So, do you think that it may have been a case of muscle patterning to start with, instead of having a structural problem, because we couldn't see any definite structural problem there?
You're right, Shekhar. So if I go back and I turn the clock back 5 years ago now, wisdom of hindsight. So I was presented with a young girl who was doing her gymnastics till the previous week in school and managing okay. Then she has a fall or stumble and her shoulder comes out. Probably in wisdom, I should have maybe tried to find out what the exact mechanism of injury, how bad the injury was. In hindsight, alarm bell should have been ringing because there was no single X-ray where the shoulder was completely out. It was only subluxing. How come the shoulder was stable when they took her to theater and they could manage to reduce it? But how come the shoulder always subluxed as soon as she came out of an anesthetic? So my alarm bell should have been ringing at that time. But you're right. That's hindsight. But at that time, everything fitted. I had a girl whose shoulder was not staying in and I had to do something to help her. So yeah, that is it. Yeah. I think Raman Agarwal has raised his hand and he wants to make a comment or question. I don't know whether we can allow him.
Yes, we can.
Hello, can you hear me?
Hi, Raman. Yes, we can.
Yeah, thank you very much. Excellent talks. I missed out on Deepak's talk, but right from Ashish, I've been listening. Fantastic. Just a comment, Kapil. I recently got caught in a posterior instability. It was a 100 kilos wrestler. And it was, my clinical diagnosis was a slap or a posterior labral tear. MRI proved a posterior labral tear, no slap. I went in. It was absolutely just a posterior labral tear and no other pathology. I repaired it. But this patient tells me my shoulder is loose. And now the situation is that I made him do dips in my OPD. He does push-ups, he does dips. Halfway through, excellent negative control, no muscle patterning. And he is my OPD. I sent him for a repeat MR scan at the same center. And now he comes with an intra-tendinous tear of the biceps, starting from the anchor, which I never believed because the biceps, I went on to the recordings of the video and everything was pristine. So I don't believe that. And then he says, my shoulder is still loose. And it is only loose when I'm pulling, but not pushing. And if it is a posterior labral injury and during pushing, he doesn't feel the pain, it's only during pulling. And when the posterior labrum is not supposed to be loaded and the pain is posterior. Then suddenly I asked him, can you show me how your shoulder is loose? And he demonstrated a voluntary posterior subluxation, a voluntary. I said, why didn't you show me this before I operated upon you? And he says, well, sir, I could do it. I always knew it. So this posterior instability, MR proven, and posterior voluntary instability, but positional, not muscular, not in adduction, at 90 degrees abduction, which ANA would say that you can go and repair a Kim's lesion. But I got caught, and this is my second episode in 10 years that I got caught on posterior instability. One patient can still not dislocate, but she still feels abnormal. And she was a woman. So this is a 100-kilo young boy, a wrestler from Haryana. And he is also having some problem with this muscular control. So I agree. I think in posterior instabilities, we need to be really, really cautious. The second thing I would want to say that I don't have much experience of revisions, but in 8 cases I have done, one has been the surgeon. I know the surgeon, who the surgeon is, so excellent. But in those days we were not doing remplissage, so I did a arthroscopic Bankart repair and a remplissage, and the patient is doing fine. But in all other cases, especially in the Indian scenario, all 7 other cases was the inadequate surgery.
Fair enough. I think, Raman, your wrestler is interesting.
Yes.
So his instability is not structural; it is muscular. He has got a voluntary contribution to it.
Yes,
he does it voluntarily, and he needs re-education. His muscles need re-education. It's interesting when he can do dips and push-ups and everything else. That means when his muscles are engaged, his shoulder is stable. When his muscles are not engaged, and he can do it selectively himself, so that is a problem. So he may have had a structural problem, which you've already addressed, but his muscle control, he needs a good physiotherapist with biofeedback, but more importantly, he needs education that he should not be doing it.
Yeah, I mean, I've spent some time, but and it is again the check boxes, and I failed to tick that box. I usually ask, can you do it yourself in any case of instability? And I remember I didn't ask him this because looking at him, he was 100 kilos and a wrestler and doing dips and all. So I didn't think of that psychological or a voluntary kind of a thing, but I failed to do that. And I think we should always ask this, can you do it? And people are usually able to do that. But excellent talks.
Thank you, Raman sir. So if we have no more questions, sir, we can conclude the session then.
Thank you.
Thanks very much, everyone.
Yeah.
Thank you. Thank you, Kapil
Good
sir.
interaction. Thanks, guys. See you later. Bye.
Bye-bye.
Thank you, Deepak sir. And thank you, Shawati sir. Hina, you have to unmute first. We can't hear you. We can't hear you.
Thank you, doctors.
Thank you, doctors. Bye-bye. Thank you.
Bye-bye, doctors. Take care. Goodbye. Thank you, all of you, for attending the webinar. Very good topic. Be safe and please take care of yourself.
Thank you, doctors.
Bye-bye.
Bye, doctors. Take care.
Thank you, doctors.
Bye. Thank you, all of you, for attending the webinar.
Thank you, doctors.
Thank you, doctors. Bye-bye. Thank you.
Bye, doctors. Take care. Bye. Thank you, all of you, for attending the webinar. Very good topic. Be safe and please take care of yourself.
Thank you, doctors.
Thank you.